Hello, my name is Thomas Furmark. I'm a professor of psychology at Uppsala University in Sweden, and I will tell you a little bit about a new study that we have done. It is called like this: Do you believe it? Verbal suggestions influence the clinical and neural effects of escitalopram in social anxiety disorder, a randomized trial, and it's published in EBioMedicine, or it's actually in press as I speak. So for the details you can check it out on this online journal. The background, selective serotonin reuptake inhibitors in comparison to placebo. Well, there has been a debate whether the SSRIs are actually more effective than placebo in the field of depression and anxiety. And in double-blind randomized control trials, RCTs, the beneficial effects of SSRIs may be explained by differences in expectancies in the SSRI versus placebo groups. Why is that? Well, it is because the perceived side effects may compromise the blinding, increase expectations of improvement, and thereby affecting subjective well-being. But it has not been tested experimentally to what extent SSRI treatment effects are influenced by expectancies induced by the information given at prescription. So in our study, 46 patients diagnosed with social anxiety disorder participated, and all were treated with the SSRI Escitalopram clinical doses during 9 weeks. It was a randomized design, and we also had neuroimaging assessment using fMRI. So in the study we compared overt versus covert SSRI treatment. In the overt group, correct information about the medication and its beneficial effects was given. However, in the covert group, these participants were given incorrect information. Patients were led to believe that they were treated with an ineffective, so-called active placebo. And for this purpose, we used a cover story. The covert group participants in this group were instructed that they were treated with an ineffective neurokinin 1 receptor antagonist, the active placebo. An active placebo lacks the specific therapeutic properties, but it gives about the same side effects as the target drug. And the stated purpose in our study was to evaluate the neural effects of the active placebo so it can be used as an improved control treatment in future research. So, first we had a credibility assessment. Each participant rated the credibility of each treatment before randomization and before treatment began. And as expected, the SSRI treatment was rated as more credible than the active placebo, as described in the cover story. So this was part of the manipulation check. Now, with regards to the clinical data, there were firstly a higher number of treatment responders in the overt as compared to the covert SSRI group. In fact, the number of responders was 3 times higher when correct information was given about the SSRI. And this was also confirmed when we looked at the change over time in social anxiety assessed with our main outcome, the Leibowitz social anxiety scale. A better treatment response in overt as compared to the covert SSRI group. And a significant difference emerged at week 3, and it was even more significant at post-treatment, week 9. The neuroimaging results, well, we assessed this with the emotional phase matching task that is commonly used. And we were able to demonstrate that there was a differential neural response to treatment. So the overt, as compared to the covert SSRI group, showed relatively increased activation of certain brain regions, including the posterior cingulate cortex, the mid-temporal gyrus, and the inferior frontal gyrus. We also saw some interesting brain behavior correlations. Reduced social anxiety with treatment correlated significantly with reduced activation of the amygdala and increased activation of the posterior cingulate cortex. And there was also some evidence of differential amygdala connectivity in the 2 SSRI groups. After treatment, the overt group showed reduced connectivity between the amygdala and the right posterior cingulate cortex and the right insula in comparison to the covert group. So there were differential activations of brain areas involved in cognition-emotion interactions. So the conclusions then, overt outperformed covert SSRI treatment. The effect size from pre to post treatment was doubled, and the number of treatment responders more than tripled on the main outcome when correct information about SSRI was given. And there were group differences also on objective fMRI measures. So clearly expectancies influence the efficacy of SSRI treatment, at least in this context when we treated patients with social anxiety disorder. But we also compared covert SSRI treatment with a waiting list or baseline control condition taken from a previous trial. And then we noted significantly better improvement in the covert group as compared to the waiting list group over time, suggesting that there is an anxiety-reducing effect of escitalopram even under these very difficult covert conditions. So our results then suggest that there is at least a moderate anxiety-reducing effect of covert escitalopram, but this needs to be augmented with expectancies or psychological factors to reach full clinical potential. And the presentation of the treatment may be as important as the treatment itself. I would like to acknowledge the work of the Uppsala Affective Neuroscience Group. Vanda Faria and Malin Gignell are amongst them. These are the two first authors of the paper that I've been talking about. With this, I would like to thank you for taking an interest in our research, and thank you for watching.